Welcome to this BS Rising Star Round 1 last session. I'll invite Dr. Neeraj Bijlani to introduce the judges and also explain the rules and the concept of the meeting. Go ahead, Dr. Neeraj.
Yes, good evening, everyone. So the Rising Star was started by Dr. Sanjay Dhar, our past president, in the year 2023, with the hope that basically we will train the new past postgraduate orthopedic surgeons to make a nice presentation and have a lot of stage presence and get confidence to present on the stage, and eventually will become the future of Bombay Orthopedic Society. So with this, today's session is mainly concentrated on the three topics. One is pediatric orthopedics. One of them is going to speak on tumors, but again, it is a pediatric topic, and a little bit of foot and ankle. So with this, I would like to introduce our judges for today. Dr. Mandar Agashe, who is a consultant pediatric orthopedic surgeon with a special interest in hip dysplasia, and Dr. Chasanal Rathod, who is the consultant orthopedic surgeon and also the EC member and the organizing secretary of the YROC, where one of you may be selected to present on the YROC stage. So remember one thing, me and Ashok, after passing almost 8 to 10 years for the first time, we presented in YROC. So this will be your opportunity and make the best of it. So all the best. And with this, I hand over back to Ashok to start the proceedings.
Thank you very much, Dr. Neeraj. I'll invite the first candidate, Dr. Ved, Dr. Yash Ved, to share his presentation and we can start. So we have 7 minutes for presentation and 3 minutes for question answers. For the judges, all these people were given a topic and they were asked to do a literature review on it. So they are not presenting a clinical topic, they are presenting a literature review and an insight from that review. Dr. Yes, you're here? Yeah.
Yes, sir.
Ashok,
Okay.
just one suggestion. Let the screen goes off at 7 minutes. It should not be that
Okay.
we'll finish it off or something. Let's be very strict about it.
Okay,
Will
sure.
that be okay?
That should be fine. But
Yeah,
only thing is
thanks.
that the presentation remains incomplete. So
No,
few
that's
seconds
fine.
I
So
will allow
they
them.
have to finish it. They have to finish. Yeah.
Yes.
All right. Yeah.
Okay. Okay, Dr. Yash, we can see your presentation. We can hear you. You can start.
Okay, sir. Is my voice audible, sir? Hello?
Yes.
Yeah, it's audible. Go
Yes.
on.
Good evening, sirs and ma'ams. I am Dr. Yash Ved, and I'm going to be speaking about the role of orthosis in the management of symptomatic pediatric flat feet. The arch, as we know, develops between 3 and 10 years of age, and the prevalence of a flat arch has been reported to be very variable in the existing literature. The concept of the acetabulum pedis was given by Scarpa about 150 years back, and this has eventually evolved to form the concept of the calcaneopedal unit, both central to the understanding of a flat foot. However, even after 150 years, the flexible pediatric pless panus still presents a dichotomy in clinical practice. This is a narrative review of PubMed and Google Scholar as the databases, and the last 10 years have been selected as the timeline. The pediatric foot is very flexible and compliant, and because of this, sometimes it undergoes a cascade of events which eventually result in a navicular sag and a flat arch. But do all of these patients with a flat arch need to be treated? This beckons the question of a symptomatic pediatric flat foot. This 2025 article of 133 studies, a scoping review, it has come up that there are 42 different symptoms which have been used in literature to be associated with pediatric flat foot. And the most common of these is pain all the way from the foot to the lower back. To diagnose a flat foot, radiological, clinical, as well as pedobarographic parameters have been used. And for the treatment point of view, we have conservative and operative options. Orthoses form the cornerstone of conservative management, and all of the several orthoses which have been described, eventually the mechanism is going to be to control hindfoot pronation. To treat or not to treat is the question. Early treatment has been recommended by several authors over the years, which have suggested that flat-foot has the potential for disability in the future, whereas other authors have suggested that flat-footedness is not a disease in the pediatric age group and they do not require universal treatment. The reason for this disparity is probably because there has been a widespread inclusion of asymptomatic children in many of the study cohorts of the studies that I have reviewed. This has resulted in inconsistent outcomes. Both of these systematic reviews, level 2 evidence, have suggested that the wearing of orthosis improves pain, foot posture, gait, as well as function in children when the insoles were used persistently for 3 months to 6 years. This has been backed by this randomized control trial published in 2018. They evaluated 52 children and obtained improvements in activity, function, as well as psychometric domains in as early as a 3-month follow-up of insole use. 76% symptom reduction was obtained in their treatment groups. This study has evaluated the long-term outcomes in which 42 children were followed up for a mean time of 4 years, and they found out that there were sustained radiological as well as clinical benefits in the treatment group. However, they found out that the outcome improvements were there in the maximum in the first 2 years of orthotic wear, after which the improvements achieved a plateau. The question of semi-rigid versus rigid insoles has been addressed in this study, wherein they have come to the conclusion that a custom-made semi-rigid insole used for 5 to 10 hours a day has better outcomes than UCBL rigid insole in both radiologic as well as barographic outcomes, probably because UCBL is more rigid, causes more pain, and hence a reduced compliance. Outcome measures I have evaluated are the radiological outcomes. This meta-analysis of 6 RCTs has suggested that overall group analysis of all the patients included showed that there was an inconclusive evidence. However, when a subgroup analysis for the symptomatic patients was done, the p-value reduced to 0.04, hence it was significant. A similar study in 200 children was done, suggesting significance of association. The pedobarographic outcomes were evaluated in this retrospective cohort study, wherein the peak medial midfoot pressures and the width of the midfoot and the hindfoot, the difference was evaluated, and a favorable outcome for the insole use was obtained. Changes in the kinematic as well as the kinetics were both in favor of the insole group, with eversion at the push-off being reduced in 85% of the patients and improving towards inversion. As far as the patient-reported outcomes were considered, this meta-analysis of 4 randomized trials has suggested again that a subgroup analysis for symptomatic flat foot has given significance. This study has attempted to evaluate the inverter-reverter imbalance which is there in flat foot. They have obtained that a peroneus longus ratio on sonography has increased with the use of insoles, and the pain and other clinical and radiological outcomes have improved. But what about the rigid variants? This study has shown that even for rigid variants, the first line of management remains to be insoles, and on the failure of insoles should be progressed to surgery. As far as the prognostication is concerned, JPO article in 2022 has suggested that unilateral involvement in slightly older children with a low pitch and a high TMT1 angle, these patients are at a higher risk of failure of conservative management, and a patient who is obese or has a tendo Achilles contracture is likely to have a persistent physiological flat foot. As far as consensus is considered, a Cochrane library review of 16 children published 3 years back has suggested that there is no use of insole in asymptomatic flat feet. In symptomatic, there is some evidence of better function and quality of life, and they recommended the use of prefabricated foot orthosis over customized foot orthosis, and customized foot orthosis to be used only if PFOs were inadequate. This Delphi consensus of 15 participants has come to a conclusion that FPI-6 is the tool which is to be unanimously used for diagnosis. Insoles are to be used in symptomatic patients to reduce the symptoms, and PFOs are to be used before CFOs. This was the clinical protocol, and this is my take-home message. Pain reduction, posture is improved, bone spatial orientation, as well as activity pattern of lower extremity muscles is improved. These are my references. Thank you.
That was nice presentation, Yash. So after studying all this, what is the earliest age group you think an insole can be prescribed? And how long would you suggest the duration, whether it's any kind of insole to be worn, customized or a prefabricated? So what's the duration? Did you find any papers or literature related to this?
Yes, ma'am. Thank you for your question. The earliest age when all the studies actually began, there was no study for below 3 years of age group. So most of the insole use was used after 3 years of age. So I think the earliest age, because the arch also starts developing at 3 years. So probably between 3 to 5 years would be the earliest time when we can start using an insole. But the developing period of the arch would still not have attained that level of maturity to have a solid assessment of how flat the foot is. In addition to this, the other question which you asked was regarding how long the insoles are to be used. For that, ma'am, there was one article which has suggested that 6 months of insole use is the minimum which is to be prescribed to attain useful outcome. However, there was one study in the review which suggested that even at 3 months, they had favorable and maintained outcomes of correction of the radiological parameters.
And if they don't see any change, how long? Like 1 year, 2 year, what would be the end of the insole? End
Ma'am,
point of wearing the.
if we don't see any change between 6 to 9 months, the insoles, the other plan should be sought for, ma'am.
Okay. Mandar, you have any question?
Yeah, Yash, very nice presentation.
Thank you, sir.
There are a couple of questions. Did you find any differences in orthotic wear between a flexible hypermobile sort of kids with ligament laxity or with other kids? And secondly, about syndromic versus non-syndromic patients. Is there any difference in role? And the last short answer is, will you give an orthosis? It's a simple question for a symptomatic flexible fracture. The child comes to you.
Sir, for your latter question, for the asymptomatic flat foot, most of the studies have recommended against the use of insoles in an asymptomatic flat foot, irrespective of whether it is a rigid or a flexible deformity. As far as your other question regarding the syndromic and the non-syndromic children was considered, I did not come across any study which was specifically for flat foot in use of insoles in syndromic versus non-syndromic children, sir.
All right, great. I think Madam is there, right? I think. Is Rujita Madam there? Or?
Yes, I'm very much there and I'm listening
Yes,
with
ma'am.
great
Yeah.
amusement. Yash,
Yes, ma'am.
there was a very prolific work done by Dr. Benjamin Joseph on flat feet many years back. Did you happen to by chance refer to it in your extensive literature search?
Ma'am, I had set my search to the last 10 years, ma'am. In that, I have not come across this article, ma'am.
Maybe out of interest, I would just recommend that you go through that as well. So he makes a pretty dogmatic statement there that if you use your feet, and even if they're unshod, as long as you're using your feet, even if you're flat-footed, like Kho and Kabaddi players, there is no problem. Would you agree with that? If so, why? Would you disagree with that? If so, why?
Thank you for your question, ma'am. I think I would first like, in this statement, there would be another level of symptomatic and asymptomatic, which I don't know if it was spoken about in that paper, ma'am. But in my review, for asymptomatic children, as you said, the comfortable shoe wear along with a regular play.
No, I'm saying they are unshod. As long as you use it, is what he says. If you use your feet, then there is no problem. So would you agree with that?
Yes, ma'am. According to the natural progression of flat feet, a lot of them do improve with age. So, if we can definitely tell the child or put the child on a regimen of observation along with comfortable footwear and play, encourage play to have an assessment of his feet and then probably take a call at a later stage if the flat feet, probably when he's closer to maturity, whether they have been.
So would you just put them on observation or would you give them any specific exercise?
Intrinsic foot exercises I would give, but again, in the literature review, it was suggested that exercise regimen was less likely to be followed by a child as opposed to playing activities such as which involve running and jumping. So I would probably encourage the parents to enroll the children in some play rather than a focused exercise regimen.
Okay. That's why he made them play Kho-Kho and Kabaddi. So this is just for your interest.
A lot of running, yes, ma'am.
Thank you, ma'am. Thank you, yes, for the presentation.
Thank you,
I
sir.
invite the next contestant, Dr. Bhushan, for starting his presentation. Please share your presentation and you can start. Okay, we can see it. You can start. We can't hear you yet. Dr. Bhushan, you're here?
Okay, sorry, I was muted, I think. Am I audible now?
Yeah, you're audible. Can you start your video, please?
Okay.
Okay, we can see you now.
So
You can start.
my previous presenter has definitely raised the bar very high with his good presentation. Today, I will be talking about pink pulses supracondylar fractures and where we stand with recent advances about this topic. Vascular complications are seen in about 2 to 20% patients with supracondylar humerus fractures, and they are broadly divided into two groups: the hands which are well perfused and pink, and the other group which is pale and dysvascular. So this is a very interesting topic for all the pediatric orthopedists and even the orthopedists in general, because there is a rich collateral blood supply around the elbow joint. And with good distal perfusion, even despite of injury to the brachial artery, is vascular exploration really necessary at all? So I have tried to conduct a study by doing a retrospective review of articles between the years 2020 to 2025. I have queried PubMed and Cochrane databases with the search terms which I have mentioned here. We included case series, systematic reviews, and literature reviews. I have excluded case reports, book chapters, and articles which talk about supracondylar humerus fractures in general. So I found 54 articles, of which 15 were suitable for in-depth analysis, and 10 full-text articles could be retrieved, of which 8 were original researches and 2 were systematic reviews. So I will start with the very basics. What is a pink pulseless hand? So if I could ask the humble judges, how many of you could suggest if this hand is pink or not? To answer this, the systematic review by Home et al. Has studied 504 patients on the parameters which I have written here. And the recommendations that they give is that skin color and capillary refill time of less than 3 seconds may be difficult to use in non-Caucasians, and we should always compare with the opposite side. Similarly, the oxygen saturation should also be compared with the opposite side. If you are treating a patient conservatively, frequent and repeated vascular examinations are imperative, and the decision should be taken by a senior member of the team. This recent study from the Ohio Children's Hospital group talks about the incidence of vascular injuries to be a dismal 0.3% as opposed to what we have previously seen, about 20 to 30% incidence. Next, let us talk about the role of imaging in assessment of vascular injuries. This very interesting study by Stork, they studied 90 patients, of which only 2 had known history of vascular complications. And on doing a duplex ultrasound scan at follow-up, they have identified qualitative changes in the blood flow in 4 patients, of which 2 never had any vascular symptoms before. So they have suggested that a duplex ultrasound can be a sensitive tool to diagnose subclinical vascular impairment. On the contrary, Wu et al. In their study suggested that Doppler ultrasound failed to assess vascular lesions in most patients, and the preoperative Doppler did not correlate at all with the operative findings in majority of their patients. Hence, they recommended doing a CT angiography, and they classified lesions as small when it was less than 5 millimeter in length and long segment when it was more than 5 millimeter in length. And patients who had a lesion of more than 5 millimeter almost always needed a vascular exploration plus minus a repair. Another study on the use of arteriography intraoperatively, either by ultrasound guidance or by the use of open exploration of the brachial artery, suggested that it was a helpful tool in diagnosing injuries to the brachial artery intraoperatively. And both the previous studies by Wu et al. And Aliva et al. Suggest that observation increases the hospital stay, need for further investigations, need for subsequent anesthetic episodes, and hence the rates of complications. Next, I want to talk about the results of treatment and predictors of outcome. Z, in their study on 13 pink pulseless hands, reported good outcomes in all patients with close reduction and percutaneous spinning at 4.5 years follow-up average. ERNAT studied functional outcomes by documenting in the PODCI and Quick Dash scores. They have reported better outcomes at 12 weeks in patients who had normal pulse exam as opposed to those who had an abnormal exam. Then there are these two studies which talk about conservative and operative treatment. In the first study by Stichauer et al., they studied 125 patients, of which 91% patients were treated successfully with a close reduction percutaneous spinning. Only 9% needed a vascular exploration. The radial pulse returned within 24 hours in a significant number of patients after vascular repair. However, the difference was not significant after 72 hours between the two groups. Then the next study has reported higher rates of complications with conservative treatment in a cohort of 74 children. They have reported that repairs and explorations produced excellent long-term outcomes, and they recommended surgical exploration if pulse is absent after reduction. This systematic review by Go et al. Was the only review which compared watchful waiting versus surgical exploration in their study. And they have included 23 articles with almost 340 pink pulseless hands. So 70.8% of patients were managed with close reduction percutaneous spinning, of which 6.3% needed to be retaken in the OT due to absent pulse, ischemia, or compartment syndrome. And almost 29% patients underwent primary exploration, in which they identified 65% patients had spasms, 14% patients may have had a spasm or a normal brachial artery, and 20% had unspecified findings. So 12 authors advocated watchful waiting, 8 authors recommended immediate surgical exploration, and 3 did not follow either of their path as a strict protocol. So vascular symptoms at follow-up were seen in 6 patients in the conservatively treated group and 24 patients in the vascular surgery group. I think it just justifies that there was a significant injury in patients who needed a vascular exploration. Their recommendation was 24 to 48 hours of monitoring post-reduction of a pink pulseless hand with Doppler ultrasound and pulse oximetry, immediate vascular exploration if there is a deterioration. Thus, pink pulseless hand in a supracondylar fracture remains a widely researched topic. However, there is no consensus about the optimal diagnostic modalities and management of this challenging condition. Based on my literature review, I feel that close reduction and percutaneous spinning followed by observation is it weighs more on the weighs more towards the treatment of this condition. However, there are a few limitations of my study. It is that this was a heterogeneous group of studies. Most of the studies have had a small sample size, which was retrospective. Barring the 2 systematic reviews, which were level 2, the other studies are all level 3 or level 4 studies, and there are no randomized controlled trials on this topic. Thus, to take home, thorough clinical assessment and documentation is must. We must plan further imaging based on our setup and available expertise. We should anticipate for difficulties. We should know our surgical capabilities. There is significant literature for or against each diagnostic and therapeutic approach. We should tailor our decision based on the scenario and do the best that we can. These are my references.
Thank you. You finished on time. I'll invite the judges for questions. Dr. Chasanal, go ahead. Yeah, Mandar, you are there. You can start.
Yeah, so I was unmuted. So, nice presentation, Bhushan. And how many studies do you think that differentiate on various investigation or various ways to confirm? So, after doing all this, what do you think is much more confirmatory in terms of using a simple pulse oximeter to a Doppler to a CT or angio? I mean, what would be your recommendation, and what is that one study which would help us to understand that which should be must done in such a case?
So I think, ma'am, like I said, there is literature to support for and against most of these modalities. So one study said Doppler is reliable, the other said Doppler is not, you should do a CT angio. And the third study said even CT angio is, it is invasive, it is time consuming, and for a small child, it will need sedation. So, I think one should assess the clinical situation and the urgency of the situation, the available resources, and then take the call based on the scenario, rather than unless obviously you could set up a protocol for such patients, but in my opinion, if you are talking about objectivity, I would say that a CT angiography would be the best to document the length of the lesion and the circulation from the collaterals, since a Doppler or an ultrasound is more operator dependent.
And was there any study which suggested that they would routinely do an exploratory, like just do an open reduction anteriorly and check for the continuity or think of a repair? Did you come across such study where they just, without doing anything, just open it in case of limited resources or certain rural areas that way?
Yes, ma'am. There was one study by Kani Muri, if I remember the name correctly, and they have suggested, this was, I think, recently published in 2024. I couldn't retrieve the full text of it. That is why I did not include it in my presentation. But in that study, they have suggested that you should do a primary vascular exploration and repair in a resource limited setting. And they have had good outcomes in their study.
Mandar or ma'am?
Yeah, Bhushan, a nice study, nice presentation. Now, see, in this pink pulseless supracondylar literature, there are always two groups: the explorers and the observers.
Yes.
The people who just pin and observe, which are the majority, and the people who say that we have to explore and repair or graft in most of the cases. And they say that what happens is that if we don't do it, there is some claudication or long-term ischemic changes.
Right.
So, two things. One is there any literature about these sort of claudication changes which happen if we don't explore? That is one thing. And secondly, have you in your practice ever experienced such claudication thing where you have conserved or conservatively pinned pink pulseless and then they have led to this?
Sir, so if I allude to the literature which I have mentioned, so there was this study which compared the two groups, one which had vascular surgery versus one which did not have vascular surgery. So in both the studies, they have identified patients who did have vascular symptoms at final follow-up. And although there was no statistically significant difference between them, but there was a few patients who had some vascular claudication. And secondly, talking about personal experience, unfortunately, I don't have, I have not had a patient with a pink pulseless who has come back with such symptoms.
Unfortunately, no, fortunately.
I was about to say that. It's fortunate that you've not had such a thing.
Good.
Okay,
So which means
Bhushan,
yeah, go ahead, madam. Yeah.
No, finish.
So which means that this sort of claudication kind of thing which has been spouted about, it is something which we have to take it with a pinch of salt, probably. About because we treat routinely pink pulses supracondylar with just pinning, and
Right.
we have not had any issues with claudication which happens. So again, so it's a
Right.
good balanced view that you have put forth. Good.
So
Thank you,
very
sir.
well presented, Bhushan. Based on the literature review that you've done, do you think for the viewers you can put across an algorithm of a protocol that would be applicable to any center anywhere with resourceful setup or non-resourceful setup? Something common.
Right. So, ma'am, if we are first talking about resource limited setting, wherein probably you don't have
No, give us an algorithm which is common,
yeah,
irrespective.
irrespective. Okay. So, firstly, it would be a thorough clinical assessment, documentation of the capillary refill, and pulse oximeter, which is, I think, available to everybody, irrespective of where they are working. Then, for a pink pulseless fracture, if the the limb is well perfused, I would suggest that the patient should undergo an urgent close reduction and percutaneous spinning, followed by inpatient observation for 24 to 48 hours. If there is any deterioration in the vascularity or signs of compartment syndrome, or the hand turns pale after close reduction, then definitely a vascular exploration plus minus a repair is mandatory. And provided that the child remains comfortable for about 48 hours, there is no signs of compartment, and the limb is perfused, I would continue to observe the patient and then discharge.
And what would you say about accompanying nerve injuries? when
So,
there's an established vascular injury.
so there are, I think, two or three studies which talk about the predictive ability of an accompanying nerve injury to diagnose that there is a more significant injury to the artery. So, arterial injury along with an injury to the median or the anterior interosseous nerve should suggest that it is highly likely that the injury is more significant and may need to be explored and repaired as necessary.
Yeah, correct. Thank you. Well done.
Thank you, ma'am.
Thank you very much, Dr. Bhushan. I'll invite Dr. Kunal for his presentation. Kunal, please share your presentation. We can start.
Yes, sir. Is it visible, sir?
Yeah, it's visible and you're audible. So you can start.
Is it visible now?
Yeah, visible now. Go ahead.
Yeah. Good evening, everyone. I'm Dr. Kunal Chaudhari, and my topic for today is acute Achilles rupture, surgery or no surgery. What do the RCTs tell us in 2025? We have all had this patient, a young athlete has a pop, and we all have seen this dilemma in this room that whether we go for surgery or no surgery. So let's go back in the beginning. What does the evidence tell us? This is my research. So this is not working.
What is not working? I can see
Yeah.
this.
No, the order of slides is.
I see your slides.
Yeah, so I came up with a total of 450 articles on my algorithm, and then matching that, when I got all the RCTs, 20 results came out. So let's go and analyze them. So the first pivotal study came in 2000, which told us the algorithm from about conservative management. But then why so much of research was done, and why has there been so much research in the last one decade? So let's look at the first RCT. In 2001, there was a pivotal RCT by Moeller, which gave us the algorithm that surgery reduces re-rupture rates to around 1.7%, and non-conservative has 20% rupture rate. It also tells us that these patients had wound complications. Before this study, the standard treatment was casting. So the next study which came up, which was very important, pivotal in 2010, was a level 1 evidence in the American Orthopedic Society, which told us that once early mobilization is added, the functional outcome in surgery and non-surgery equalizes. In 2010, there was a very pivotal paper from JBJS, which told us that accelerated functional rehab reduces re-rupture rates. Surgery creates more problems than it solves, therefore we can reserve it for special cases. Moving on, in 2011, there was a study from the Journal of Bone and Joint, which was a prospective RCT, which gave us 80 patients. And specific thing about this study was they used isokinetic muscle dynamometry. They told us that functionally surgery is not better, and the only advantage was slightly faster recovery and lower re-rupture rates. So this study propagated conservative management. In 2012, there was another paper which was a meta-analysis from JBJS where they assessed 10 RCTs and told us that surgery was superior because it reduces re-rupture rates, but it created more problems of complications. And on assessment, there was no meaningful difference. So that told us that if in early cases, patient comes to us and the outcomes of surgery and conservative are same, so we can go for conservative management. In 2013, there was a paper from American Journal of Sports Medicine, which was a 11-1 RCT. In that, they told us that early full weight bearing is safe in both cases, surgical and non-surgical cases. And at the end of 1 year, the functional outcome of surgery and not surgery are same. Stable surgical repair with accelerated loading did not demonstrate superiority. They also added a comment that the surgery had a lot of wound complications, so we can go for conservative management. In 2016, there was a very pivotal study, which was a level 1 RCT from the American Orthopedic Society of Sports Medicine, which gave us the conclusion that surgery restores the calf strength faster and more completely. So we can consider surgery for highly active and athletic patients. Surgery and or conservative surgery becomes better than conservative management, as it gives strength recovery and gives better confidence for the patients so they can go back to their routine activities faster. In 2017, there was an RCT from again the American Journal of Sports Medicine where they assessed the soleus muscle volume and fatty degeneration and TL lengthening. This RCT again supported surgery in that it told that in non-operative cases or conservatively managed cases, there was more tendon elongation, which resulted into more soleus atrophy, and that resulted into strength deficiency. Surgical repair, on the other hand, protects the tendon length and limiting muscle disuse. They gave us the motto that structure predicts function. So if we restore structure, the function recovery is better. In 2017, there was another RCT and a meta-analysis from China, which told us that both treatments worked well if an early rehab was added. A good functional rehab with a good patient profile selection can give us a good outcome irrespective of whether you're doing surgical or conservative management. Surgery does significantly reduce re-rupture rates, but functionally at the end of 1 year, there was no difference. In 2019, there was a paper from BMJ that told that surgery reduces re-rupture rate by a small margin, but increases the wound and sural nerve damage complications. So final decision should be an individualized approach. In 2020, this was the longest follow-up study of minimum follow-up of 13 years with a maximum follow-up of 16 years with a mean follow-up of 15.7 years, which told us that surgery does not improve long-term outcome, but also gave us the mantra that biggest predictor of outcome is the functionality which the patient has recovered at the end of 1 year. This tells us on the basis of rehab and tendon biology that outcomes can be good irrespective of surgery versus conservative. In 2022, non-operative or surgical treatment, this was a pivotal paper from New England Journal, which told us that surgery and conservative have same outcomes, and surgery reduces the chances of re-rupture by 5.6%. But with the introduction of MIS, there was improvement in complications of wound healing, but at the same time, there was increase in nerve injuries. Rehab quality is now the major determinant factor for recovery. In 2022, this was a paper from Italy that gave us an algorithm as to how to manage it. To avoid re-ruptures, we can go for surgery. But if in patients which are comorbid and you are expecting wound complications, you can go for conservative management. In high demand patients or sports patients, you can go for MIS with an early rehab. And young athletes also can benefit from this. If the patient is old or comorbid, you
We
can
have
go
just
for.
half a minute left, huh, Dr. Kunal?
Yes, sir. This is a study about gait analysis, which told us that Copenhagen Achilles rupture treatment algorithm did not show any difference in surgery and conservative management. In 2024, this was a paper from China that told that good rehab is must, and 2025 also told us that good rehab was very important. PRP was also assessed in this, and there was no proven role of PRP in case of TA and lengthening. So this is my take-home message: treat the patient, not the rupture. Surgery and conservative management have same outcomes, but early rehab is must. In high demand patients, you can go for surgery and MIS. In low demand patients or comorbid patients, you can go for conservative management. And rehab forms the basis for management for as a strong predictor for success. That is why I would like to conclude that at the end, you should do an individualistic patient approach, and surgery is not meant for everybody. So patient selection becomes the pivotal part for patient management. Thank you.
Thank you, Dr. Kunal. Judges can ask the questions. Chasanal, if you're here, we can start.
Yeah. Yeah. So nice presentation, Dr. Kunal. But do you think that the papers which say that you can conserve, do they, the biomechanics, what does it say? That do they have a weak push off? Are they okay to go around doing regular activities?
Yes, sir.
And what about the newer ligament augmentation products which are now available? Maybe the autograft or the allograft, which are not the grafts, basically the synthetic mesh kind of thing which I use. you didn't mention any of those in your literature review. So
Yeah.
you want
Yeah.
to
Yes,
highlight
ma'am.
about
I'd like
it?
to address both the questions. Thank you for the question,
Yeah.
ma'am. First question about the push-off phase. So, ma'am, the main problem here is the TA elongation. We don't want a elongation. This was told in a 2023 RCT by Hansen. I had mentioned it. I just didn't describe it in too much because there are many RCTs I had to describe. So that RCT talks about the biomechanics. In that case, when the patient is walking, there is always at the end of 1 year, there is seen an increase in ankle dorsiflexion and a reduction in plantar flexion. This is because the TA elongates, which reduces the force reduction, which is propagated by the TA. And when the patient is walking at the end of plantar flexion, there is a weak plantar flexion. So the patient goes into more increased dorsiflexion. So the patient expends more energy while walking at the end of 1 year. So in that, at the conclusion of that 2023 Hansen's paper, they did mention that rehab is very important, because with a good rehab, you can prevent a TA elongation, because a TA elongation more than 7% results into more energy expenditure as compared to 7% is the marking point. And about the second part, ma'am, the artificial poly meshes which are available in the market,
Hmm.
they are in India. They're marketed by the company Xeros. So they were initially made for ACL, but now have been coming into foot and ankle also. So these mesh cages are actually they are bridging gaps for gap filling. So the role of these meshes in acute Achilles rupture is not there. They are meant for chronic cases. In my fellowship, I had assisted on some cases where the Xeros or the mesh were used to fill a gap. But their indication, I think, is very specific right now, that when there is a gap of more than 3 to 4 centimeters and you can't do an FHL transfer, or if you want to augment your FHL transfer and you don't want donor site morbidity such as a semitendinous graft, then you can use a mesh. Yeah, ma'am.
Okay. You call it Kairos or Xeros?
Xeros. X.
Yeah, it's X, but it's pronounced as
Oh, sorry.
Kairos.
Sorry.
Yeah, no
Yeah.
worries. Okay, great. Nice presentation.
Thank you, ma'am.
Mandar, you have any questions? Ma'am?
Yeah, very nice and exhaustive presentation and literature search. So, see, traditionally, when we were from our residency time, the two confounding factors for tendinoachilles were always diabetes and smoking.
Yes, sir.
So, did you find any literature about whether to operate it? I don't know whether you mentioned it, but
Yeah.
these are two things which are always important in terms of healing and everything.
Yeah.
So, is there any literature regarding these 2 points?
Yes, sir. Yeah. So the best literature is the one paper by Yang et al., which is from 2025. There were older papers also which were mentioning, but the most number of things were mentioned by this paper. The newer list to the previously which you two added, sir. So other things which I will add in the after my research is also obesity, patients who are on chronic dialysis, patients who have been taking corticosteroids for more than 6 months, patients who are on immunosuppressive therapy, and patients who have had previous ruptures or previous insults to the TA. All of these patients fall into the high risk category, and I can consider conserving them in a cast. And at 2 weeks, I would try to repeat a USG to see if the TA elongation is more than 7%. If there is increase in TA elongation, then you can go for something else. But other than that, these patients I would like to conserve.
Okay, great. Thanks.
Thank you, sir.
Dr. Kunal, what would your recommendation be for a housewife post-COVID who lives in a chawl and has to do most of the work herself? Would you conserve? Would you operate? Would you operate with some caveats?
Ma'am, can I ask some question?
I
Yeah,
thought that was my role.
can I know the age of the patient and her comorbidities?
Housewife. Oh,
So
definitely
40,
above. Yeah,
40,
okay.
50.
Take it
Yes.
as that.
And ma'am, is she diabetic? Are there any
So I'm
comorbidities?
not making up a patient. You have to
Okay, ma'am. Then I would
make a
like to go for
generalization
operative
and
management. I
Yeah,
would go
okay.
for operative management, but at the same time, I would do a USG because the USG has a 98% sensitivity in this case, and that would tell me the retraction. It would really depend on the retraction, because if the retraction is less than 5 mm, that I would definitely conserve. If it is more than 15 mm, I would go for operative. In her case, if it is between 5 to 15, I can consider doing a conservative management, but considering her activity and she's doing a lot of work by herself, she falls in the gray zone. If it is 5 to 15 mm of retraction, I would like to go for surgery.
But how practical would that be for somebody who's living in a chawl, has to go up and down stairs every day for daily life?
Yeah, ma'am, I agree with that.
And
But
considering that she may not have enough facilities for bed rest, for
yeah, ma'am,
conservative
but
treatment.
consider actually after literature review, in surgery, you can start the physiotherapy earlier, and in her case, I would do the surgery, and after a small period of cast, I would give her a walker boot, or I can make her start walking in the cast also, and eventually just increase the degrees, or in if she can afford a walker boot which is 4,000 or 4,500 rupees, so then I can give her wedges which I remove every 10 days, so she can start doing her activities after a brief period of cast. If I would was doing a conservative management, she would be more bedridden for a longer period of time, and
That's why I
even
give you the scenario first. Anyway,
yes,
let's just a tip from my side. Consider giving shorter to the point answers,
yes.
at least not longer than the examiner's question.
Sorry, ma'am. Sorry. Thank you, ma'am.
It's just a tip, nothing to be sorry.
Yes. Thank you, ma'am.
Okay.
Thanks a lot. Dr. Samarth, you can share your presentation and we can start with you. Yeah, we can see your slides. Unmute yourself so we can hear you.
Am I audible, sir?
Yeah, you're audible now. You can go back to the first slide and you can start.
Good evening, everyone. I'm Dr. Samarth. I'll be discussing on adult tarsal coalition in young adults, the decision making and outcomes. Adult tarsal coalition is far explored and under researched topic as compared to the adolescents. There are a lot of lacunae in scientific understanding, starting from the prevalence, where the older studies said it was barely 1 or 2%, but the newer ones say 13%. The natural history is also under discussion. People wonder why the adults precipitate with painful foot while they could successfully escape the precipitation in adolescence. And lastly, the secondary changes that occur with coalition and living with it into the adulthood are being discussed. Is arthritis a rule or an exception to such cases? We went through a lot of papers into the literature from 2015 and later. I think I lost my video.
Yeah, you can go ahead,
Is it,
Samarth. Now it's visible.
yeah, but it's not coming on my screen, I think.
We can see your slide. What's wrong?
I'm only able to see my own video feed.
Hmm.
Which device are you using?
Laptop.
So just stop the screen share first.
Okay.
Press escape.
I've stopped it for him.
Now can you see it?
Yeah, I can see. 1 second. Yeah. So the methodology, we went through electronic database, going through papers from 2015 and later. Some seminal papers before 2015 are also reviewed. The natural history of coalition centers around reduced mobility and abnormal alignment, both of which lead to abnormal joint forces, leading to adaptive changes in the growing skeleton, such as talar beaking, shortened peroneus brevis, and eventually arthritis in adulthood. The spectrum of presentation is wide from adolescents to old patients. Largely in adults, we see asymptomatic incidental cases, but the ones that present with pain have varied pain points. The pain generators could either be the stress reaction at coalition site, impingement at sinus tarsus subfibular, peroneal pain, which is uncommon, or there are some unique pain presenters in the adulthood, which are the large talar beak causing dorsal tissue irritation, or the arthritis of the subtalar, talonavicular, or ankle joints. Conservative therapy has stood the test of time. It is recommended as the first line treatment by most studies, which shows 60 to 80% satisfactory pain relief after 4 to 6 weeks of casting, followed by activity modification and accommodative soft orthotics. Despite literature support, there is a debate whether aggressive coalition excision or resection in younger age group preserves the mobility and preserves the biomechanics to prevent future complications. Surgical treatment goals are centered towards removal of coalition, achieving the deformity correction, and lastly, restoring the mobility and biomechanics. For CN coalition, the operative treatment is resection and interposition. A wide block excision, at least of 1 centimeter, is suggested. The interposition tissue is debated upon, but Maschio in his study shows that the best results are possible with fat and bone wax used as interposition. Coalition excision for CN has stood the test of time, but there are always discussions around whether the movement and biomechanics are truly recovered. Studies by Hestroni and others have shown that they do not come back to near normal, but the pain relief itself is enough for patient to have better AOFAS scores. Complication of CN excision are largely wound dehiscence, which happens much more with EDV grafting, in some cases sural dysesthesia. For CN coalition, fusion is restricted only for arthritic indications, and it's seen in fewer number of cases. In patients with recurrence, again, fusion is a choice of operation. So fusion surgeries vary, either double or triple fusion as per the arthritic joints affected. Operative treatment for TC coalition is far more challenging. The decision making and the technicality of performing both are challenging, largely because TC is a deep-seated joint with variable anatomy, with difficult to access the joint, especially in a sloping sustentaculum tali, and overdoing or underdoing bears with the surgeon the risk of iatrogenic injury as well as leaving behind residual coalition. The question remains, if after complete resection, the residual cartilage may be too little to sustain all through life and lead to arthritis in the future. The size really matter. The discussions go on. There are different ways of calculating the amount of coalition which is affected, and most surgeons and most studies have stuck to the 50% rule, although there is no strong evidence behind this threshold. Studies by Mubarak and Koshbin have found that regardless of the size, surgeries, if performed well for deformity correction, give equally good results. TC coalition classification by Rozansky Mubarak using the CT have really helped in understanding the size, location, inclination, histology of the coalition tissue, and helps monumentally in the preoperative planning. TC coalitions, unlike NC, lean more towards fusion, especially in the adult population. The indications are arthritis, especially not taking into account the talar beak, significant deformity more than 20 degrees, which, if left with resection, sometimes leads to poorer results in arthritis in future. Larger surface area, as discussed earlier, and largely in cases where the resection is too difficult to do, or despite resection, the rigidity persists. Arthroscopic resection is a fairly modern method, and various approaches have been shown. The studies are yet to prove its superiority. Use of 3D printing and navigation have also shown great results, but the studies are small and yet to show the superiority over traditional open approaches. Deformity correction is an essential and unavoidable part of any coalition surgery. There is a host of procedures available. Mosca et al. Preferred calcaneal lengthening, while the newer studies show arthroeresis. Essentially, a cafeteria approach is recommended. In cases of multiple coalition, which is almost up to 10% of the patients, often the treatment is centered towards fusion and salvage is difficult. Decision making, if one wants to summarize, firstly, it involves weight-bearing analysis, clinically, radiologically with X-rays, and if available, a weight-bearing CT and also an MRI. The second step is generally always to take a conservative approach first, especially in patients with first-time pain and those without arthritis. And lastly, as discussed, surgical treatment with resection interposition is chosen if there is no arthritis, if there is less than 50% TC coalition, and if there is less than 20-degree deformity. In other cases, the chosen line of treatment is fusion with correction of deformity, which is an essential add-on. Conclusions: the adult tarsal coalition has limited literature to support any strong treatment recommendations, but conservative treatment is generally the first line. CN coalition tilts more towards use of resection and interposition, while TC coalition tilts more towards use of fusion when it comes to adult coalitions. Deformity correction is unavoidable essential part. Here are references. Thank you.
Thank you, Dr. Samarth. I'll invite judges for questions. Snell Mandar, if you are on, you can start.
Yes, Samarth,
Yes,
nice talk. So I think, as you can see with the previous presentations also, the main crux of the matter should have been more of literature review rather than a narrative summary or sort. So I think that is one comment I would like to make, that it should have been more based on uh, the actual articles rather than just a summary. That is one thing. Secondly, you quoted Mubarak quite a lot, and you said that Mubarak is more likely or more in favor of calcinal lengthenings. So is that
Mosca.
You said Asha? You said
Mosca.
Mosca. Okay. Because I thought you said Mubarak was. So what did you say about Mubarak? So I think you went quite fast at that time. So
So Mubarak had one come out with the classification along with Rosansky, the 5-point classification,
correct.
which is very monumental in operative planning, from first to fifth one. And other than that,
Correct.
Mubarak probably, no, that was Mosca. The lengthening was Mosca.
Exactly.
So Mubarak
So
also, I think,
because
yeah, he was against the calculation of percentage for the coalition region, the area, and he proposed that if the coalition is resectable, one should resect it. If it is too big to resect, one should just focus on the deformity correction and leave the resection as is. Deformity correction itself is going to give pain relief to the patient because stress on the coalition tissue goes up.
correct. So that is exactly the point. Point which okay. And I don't think that it was put forth in that manner in your presentation. That is what I was a bit confused. That's fine. All right, great. Madam, are you there? Or
Yeah.
Chasanal?
Yeah.
Yes.
Ma'am.
So, Samarth, tell us what literature says about interposition arthroplasty and what materials are the best for it. Not your opinion, huh? What literature says?
The literature says that around 4 or 6% of recurrence is seen with use of gel foam or bone wax and use of fat grafts, but up to 40% of recurrence and complications are seen when using EDB. This is regarding the CN coalitions, and the earlier studies in fact had EDB used first, and when they saw these complications, they shifted to gel foam, and then they got lesser complications and they were stuck to that. The explanation given for this result is that EDB volume is one less, so that it does not fill up the space completely. Number two, mobilization of EDB is not that easy. It can only partly mobilize. And even if mobilized, it leads to a hollow space in the subcutaneous region leading to wound dehiscence. Due to these reasons, the shift of culture towards using fat and gel foam or bone wax has been the present case.
Any newer modalities that you are aware of, which are used for the coalitions?
Newer modalities as interposition?
Yes.
I came across the use of ITB, iliotibial band, or TFL grafts to fill up the void. Barring that, I'm not aware of.
So maybe the foot and ankle surgeons don't use it, but in pediatrics, sometimes we use TISIL or tissue glue, which functions better than any of the biological materials because it retains the subtalar motion, which is very, very important in a talocalcaneal coalition. But I agree fully with Mandar. It shouldn't have been a lecture. This was meant to be a literature review.
Okay.
Yeah. So
Okay.
Okay, we'll go to the next one.
yeah, we can go to the next.
Chasanal is Chasanal is
No,
there
nothing.
for question.
I just wanted to tell him the same thing, that since it's a very rare topic, it would have been nice to make the literature based on case series or retrospective, and the way it should have been, the content should have been planned based on the literature search. It's not a regular
Right.
topic. Yeah. Anyways, it was a nice presentation. Yeah. Let's go ahead.
Thank you.
Uh, am I audible?
Yeah, you are.
Yes, we can see you.
Good evening. I will be presenting on management of osteoid in 2025 and the current trends. So osteoid is seen mainly in the first decade. First 3 decades was the third most benign bone tumor. Sorry, the screen is. So the pain, basically this presents with pain, which is typically worse at night, and it relieves with NSAIDs are typically due to the prostaglandin E2 production, which is relieved with NSAIDs, which is a COX inhibitor. This is mainly in the lower limb. It's a cortical-based lesion in the diaphysis, in the femur and tibia, but it's also seen in vertebral posterior elements and also flat bones. With the radiology, the first is X-ray is done, and X-ray can show a cortical thickening. Sometimes they're normal, and if the nidus is pretty big, it can be seen on X-ray. But CT is the modality of choice with the central nidus of less than 2 centimeters. Sometimes MRI also are done, and the MRI will show edema. Diffusion-weighted images, which is also seen in T2, can be good to distinguish osteoid with other benign bone tumors. Sometimes bones can be done if the diagnosis is complicated, which shows a double density sign, which is an intense central uptake surrounded by a lower uptake zone. I have used PubMed, Google Scholar, SciSpace, and Consensus for today's literature review. So this may be divided into surgical methods and ablative methods. Surgical methods, so first is a non-block excision, which is obsolete now, though it can be used sometimes if it is very close to the articular surface. The second is a percutaneous CT-guided drilling. Third is a navigation-guided percutaneous drilling, which is done in the OR. And it can also be done with a CT-guided Kirshner wire insertion, where the K wire is inserted in the CT room and the patient is shifted up to the OT, and through that a minimal incision is done, and the nidus is burred out. This is the navigation system and a CT-guided drilling. So first, these are the two papers which were mentioned by Rosenthal, which was done in 1992 and also in 2003. These were the landmark papers for osteoma to shift the paradigm from surgery to ablative methods. So he mentioned for open surgery, though the success rate was 90%, the complications of fracture, infection, hematoma were at around 20 to 45%. The newer surgical methods have been devised. There is a percutaneous CT-guided curettage of the osteoid where there were 18 patients. It was 88%, and the recurrence was then repeat procedure was done, which is a 100% success rate. Only two complications of skin-related and a femoral neuropraxia, which healed on its own. Another paper which came out of Brazil was a CT-guided percutaneous drilling, which are safe and reliable methods with 15 patients, no recurrence. They did face one fracture and one atrophy of the vastus lateralis muscle. The fracture patient was more because he started heavy impact activities at a very short duration. Another paper which has come out of Ganga is the use of an intraoperative CT navigation feasible for excision of osteoid osteoma, where they evaluated 58 cases over a period of 45.6 months. There were no recurrent lesions, and 2 patients only had a superficial infection. So this is the system where they used the navigation, which was for a distal tibia, for a navicular, osteoid osteoma, where the pins were placed at the in the tibia, and curettage was done, which was navigation guided with a small incision. Another thing was open surgery for osteoid osteoma with a CM 3D CM scan under the computer navigation, which has come out of China, where they used 14 patients. The VAS score decreased from 4.6 to 1.4 over a period of 6 months, with a blood loss of 50 to 150 ml, where the curettage using a burr was done under navigation guidance. Radiofrequency ablation is now the gold standard, which is used for the treatment of osteoid osteoma. This was mentioned by Rosenthal in 1992, and there have been numerous articles which have been published since that time, which showing a success rate of more than 95%. Basically, it is placing the J needle into the nidus where the probe is passed, and 90 degrees Celsius of heat is given for 5 minutes. So I would like to show what new is done in radiofrequency ablation, where you can do a robot-assisted percutaneous radiofrequency ablation, which has come out of China, where 21 patients were done. They have a T-robot, which was done where no complications were seen. VAS score had decreased to 0.5. So the placement of the guide into the through the J needle into the nidus was done using a robotic arm. Another paper which came out of China again was the O-arm navigated robot assisted versus a conventional CT guided ablation. So the most important fact is the operative time, the radiation which was used, and the KVAR adjustment time came down significantly less. But the technical success rate and the VAS score came down were pretty much the same. So operative time, radiation, and KVAR adjustment time were the main factors which were affected. Another method was an interstitial laser photocoagulation, where laser light is used for protein denaturation. For this, there is a study of 35 cases which are done, which a technical success of 100%. The only drawback of this procedure is the 11.4% complications. So they compared other articles as well. And the other articles also presented complications, which was mainly related to skin-related complications, and also patellar-tendon enthesopathies and sacroiliac when used at the spine. Microwave ablation is another technique where they use the water is used. There is the water is targeted. The water molecules are targeted to create the heat. So 28 non-spinal osteoid osteoma were treated for this. Contrast enhanced MRIs were used for follow-up at 3, 6, and 12 months. There was a 93% success rate, and they were repeated, and there was 100% success at the repeat. None of these papers have really suggested to moving into surgical management from ablative. There were 3 minor complications. So this paper compared a radiofrequency ablation and microwave ablation for osteoid osteoma, and they found the technical success being more in microwave. Technicality was better, but this is more related to the surgeon preference, and also the intervention radiologist preference and the use of the equipment. Cryoablation is another technique which has come out where the temperature drops to minus 20 degrees. There is a freeze-thaw freeze cycle which goes on for 30 minutes. This paper from Greece showed 25 patients with 100% clinical success. VAS score dropped to 0 at the end of 1 year, no complications, no recurrence. And the advantage of this is the needle can be placed extraosseous as well, very near to the cortical lesion, and we can have the formation of this kind of an ice ball near it with, and the freeze will destroy the nidus. So there was another paper at the percutaneous cryoablation under conscious sedation for the pediatric osteoid osteoma, where it had 9 patients, no recurrence, 100% technical success. Technical success is judged on the repeat of the procedure or repeat placement of the needle, which was not needed, and there were no complications at all. So the latest technology or latest modality which is out is the MR guided focus ultrasound. This is a very new technology, still under trials and under research. So this was the paper from China, which focused on the efficacy and the safety of an MRGFUS. There were 113 studies where they found 353 patients which were done. There's a technical success rate of a 92.8% with a minor complication of 0.85%, which was again skin-related changes. There's a transducer that is placed at the skin and the lesion is targeted. The only problem we can face in an MR-guided ultrasound is the precise target of the lesion. So, but the success rate is good, and there are studies ongoing for this MR-guided ultrasound, and they actually lack support currently, but it is still under trials. So my conclusion is, while open surgery was historically the standard, it has now become obsolete due to higher morbidity and longer recovery time. Thermal ablation techniques have 100% for range from 90 to 100% success rate, minimal complication, and rapid return to activity. Once the ablative techniques have started, all of them have been started weight bearing from that evening onwards or the next day, and it's just been a 24-hour admission. MR-guided focus ultrasounds is a promising non-invasive alternative technique, though long-term evidence is still emerging. In 2025, optimal management strategy is very individualized, and guided ablative therapies remains the first line, with RFA being still the first line of treatment. The primary success rate is still comparable, though the problem we have with other modalities, including the cryoablation or a microwave, is in an Indian scenario, is the availability of the instrumentation and also the cost related to it. RFA comparatively is cheaper. The needle can also be used for the same patient if he requires a repeat RFA procedure. So my take-home message is trends in 2025 is shifted from open to percutaneous surgery to ablative to newer ablative modalities to a non-invasive modality. Open surgery is now obsolete. Treatment is very individualized on location, accessibility, and equipment availability. And there is a significant paradigm shift to faster recovery and return to activity with reduced complications and increased accuracy. These are my references. Thank you.
Can I go first?
Yeah, ma'am. Please.
Amar, the literature seems to be making me obsolete, but I'm big believer of doing something simple. So, are we justified in thinking that the newer the literature, the more technology driven that it is, you kind of tend to want to write a paper to say that this is the best. But
Yes.
seeing the number of white hair on my head, should we reserve it for inaccessible areas? And
sorry.
where the risks of open surgery outweigh the benefits?
Ma'am, thank you for the question. I feel, ma'am, with the newer modality, especially if we still keep cryoablation and microwave and all aside, keep it to as simple as an RFA, over the long run, with the morbidity of surgery, with the cost involved, with the admission, and with the OR time, I feel RFE is a very good solution to an osteoid osteoma, especially because you can get to activity by that evening itself. There is no restriction into weight bearing, because when we use surgical management, it's about removing that entire segment of nidus. That entire cortical area is done. So a lot of surgeons would want to restrict weight bearing, restrict activity for some time, but that is not the case when you use ablative technology. Ablation per se has a very good success rate, and overall for the patient, I feel ablative technologies are still are better. So, keeping all that in mind, I feel that surgery is becoming obsolete because even when they have had recurrences, a second ablative procedure have had a 100% success rate.
Yeah. Okay.
All right. Can I go ahead?
Is there, yeah, you want to ask Mandar, or can I just continue?
Yeah.
Yeah.
Yeah. Can I just ask a question?
Yeah, ask. Go ahead.
Yeah, Amar, you are, I
Yes,
think, quite a bit biased towards the foreign literature. There are three important articles or I mean groups which have published quite a lot. One is Bhavin Jankaria has a very nice paper on
Yes.
radio frequency ablation.
Yes, sir.
Second,
Yes, sir.
Rusha Madhuri and the CMC group have a couple of papers on
Yes.
RFA, if I'm not mistaken. And thirdly, I have one of the largest series from India, which has been published in 2020, which we have not mentioned at all,
Yes.
about CT guided percutaneous bleeding.
Yes, sir. I'll just yes, sir. So,
Yeah, so I
sir,
think
I
you
was
should not
just
be biased about
the reason I
just
have
the
seen these
foreign and the
articles.
modern one.
Yes, sir. Sir, can I just answer that, sir? So the only reason is I had skipped RFA in general because I was focusing more on because there have been a lot of RFA articles which are there, sir, and RFA shown a very good result. The only reason I had showed the other articles in RFA was to see the newer modalities, what and to better the accuracy in RFA. So I had just quoted the articles of the latest developments in RFA.
Okay, and the percutaneous drilling ones?
So the percutaneous drilling ones, sir, I've shared the couple of them, which was the CT guided percutaneous drilling of the nidus.
Okay, so you can search for the latest of them in 2020.
Yes, sir.
Um,
All right?
I was about to
Yeah.
tell you the same thing, Amar, that you didn't mention about the Indian papers. And secondly, do
Yeah.
ablative procedures cause disturbances around growth plate in pediatric population? So did you come across any of the papers, of this?
So none of them, whichever papers I have actually gone through, have not mentioned any growth abnormalities. Mainly, a lot of them because they are actually diaphyseal lesions, but some can come near the joint. But none of the
Yeah.
ablative technology, the ablative series have mentioned specifically growth abnormalities.
Okay. Great. Great. Thank you, Dr. Amar. Yeah.
Thank you. Thank you, ma'am. Thank you.
Next is Sheenam. Are you ready? There.
Is it visible?
Yes, please make it a slideshow.
Okay, yes. Uh, yes. Can you see my full screen?
No, we cannot see your full screen.
Okay. Mm.
Chasanal, you can see her video.
No, I can't. Neither video nor the PowerPoint.
I think you should unshare the screen first and then
Yeah, she
go
did that
on
once.
and share again.
वीडियो भी नहीं दिख रहा है उसका
Is it
लैपटॉप बहुत स्लो है
is
या
it
इंटरनेट
visible
बहुत स्लो
now?
है
No.
No.
No, either your laptop is very slow or your this is very slow.
You should
Internet,
have
one of the two.
logged in little early. Everyone checked their slides, Sheenam, except you. The timing was 8:30 to log in. We can't hear you. Can you hear us, Sheenam? Are you there?
No, her audio is not connected.
Her audio, the symbol is also gone, and so
Just put on your mic first. Let's see if your sound is coming.
Sir, is it visible now?
Yeah, but we can see only the folder. We cannot see the PowerPoint which is starting. I don't know whether it has started or not.
It started here.
So just do one thing now. Follow my instructions step by step. Stop your screen share.
Okay. Stop.
Now, when you click on screen share,
Yes, sir.
you select the first option, that is the whole screen. First option on the left. Screen, ऐसा लिखा रहेगा, screen लिखा रहेगा, desktop लिखा रहेगा.
Yes, sir. Yes, sir. I
उस पे डबल क्लिक
selected that.
कीजिए.
Okay, done. Is it visible now?
Not yet. I think your internet or laptop, now it is visible. Now you can start the screen play. Yes.
Okay. You can see the starting. Okay.
Yes, I can see the PowerPoint.
Okay. So my topic is clubfoot relapse after Ponseti method, role of bracing adherence, and timing of TA transfer. So as we know, firstly we achieve the correction or stretching with the casting. Then we do the tenotomy to achieve the dorsiflexion. Then for the maintenance of correction, we apply the brace and we do the tibialis anterior transfer for the muscular balance. I would start my topic of role of bracing adherence with this picture. This paper was published by Professor Morkande with the engineering team. This picture shows the percentage change by applying standard of care brace in the clubfoot. So this is a percentage change in the muscle tendon tension with the brace, with the standard brace. So this is a paper which was published in 2012 in the JCO journal. This paper concluded that in the posterior medial compartment in the clubfoot, if we compare it with the normal, then there is increase in 9-fold muscle from age group 2 to 3, while the difference in length increased by 20% in the normal as compared to the affected. So these are the three age groups. So age group 2 and 3 were the from the age 10 months to age 6 years. So this is the affected side. We can see the muscle is very less as compared to the normal side. So these are the papers from year 2004 to 2025. These papers revealed that the relapse were related to non-compliance with the foot abduction brace. This is a paper which was published in JBJS 2012, which revealed non-compliance with the bracing is the most common cause than other causes. Then, if we compare with the starting age of casting and the other factors. This is a paper which was published by Dr. Els in 2019 in JCO. She also revealed that bracing is essential for preventing clubfoot relapse. This is a paper which was published in 2017 in Bone and Joint Journal. Now I come to the timing of TA transfer. This is the paper which was published in 2017. If we compare the lateral cuneiform At 1 and 2 years, the ossification center of lateral cuneiform may not be large enough to accommodate a drill hole for tendon transfer. However, by 3 years, it undergoes ossification. So we start the TA transfer at the age of 3 years, as my topic was timing of TA transfer. Then this was the paper which was published in 2022 in JPO. This paper concluded that TA tendon to ossified lateral cuneiform width ratio ranged from 44% to 53% across age of 3 to 6. The drawback of this paper was they didn't take in control the other ages. This was the paper which was published in 2010 in Bone and Joint Journal. They compare if can they do the transfer of TA tendon to the other bones which are ossified early. Then they concluded that if they transfer to the base of third metatarsal and the base of fourth, then there was undercorrection and overcorrection, which which resulted in triple arthrodesis and subtalar fusion in the future. So this was a paper which was published in 2025 in Journal of Posna. They concluded that, so now we talked about the biological clock, but this paper spoke about physical clock. That if there is varus equinus, then we need to correct the structural deformities first. Otherwise, recurrence will occur. But if there is dynamic supination, because it is dynamic but not structural, so here TA transfer will result in better outcomes. So here mean age was 5.8 years for tendon transfer. So I conclude with there is decreased muscle mass in the clubfoot patients and there is decreased length in the affected side. So braces can lead to the stretching of the muscle and because of stretching there would be muscle development. So the perfect age of bracing is 2 to 5 years, which is a perfect age, which is the actual age of muscle development. Transfer of tibialis anterior to lateral cuneiform provides muscle balance. If we transfer to other ossified muscles which ossify first, then we may lead to undercorrection or overcorrection. So adequate time of transfer is 3 to 6 years, where lateral cuneiform gains adult size. Thank you.
Yeah, thank you, Sheenam. So,
Okay.
did you compare the literature about transferring it just to the lateral cuneiform or the middle one? And should the transfer be a split or full thickness? So, this was just about the timing, but did you do the literature search related to these 2 points?
No, ma'am. I didn't compare with the split and full thickness.
Okay. And you mentioned in the last point that maybe transferring it to lateral cuneiform can cause overcorrection. So did you find that one of the
No,
points you said it could lead to
if we,
overcorrection?
yes, ma'am. If we transfer to the lateral cuneiform, then there would be no overcorrection or undercorrection. But if we transfer to other medial or lateral tarsal bones, there would be undercorrection or overcorrection.
Okay. Mandar,
Okay,
you have
Sheenam.
any?
Yeah,
Yes,
Sheenam, you
sir.
said the ideal age for bracing is 2 to 5 years. What do you mean by that? 2 to 5?
Sorry, I think I spoke wrongly, age 2, but this is after achievement of correction. Uh, that may be the slip of
Okay.
tongue. Sorry.
Okay.
Yes.
Okay.
Can you tell me with a hand on your heart whether you just read through the abstracts or you've really gone through these entire papers?
Ma'am, I read all the papers. as I took
Full
very
text.
few papers. Yes.
So when you've done so many fellowships, we expect that you will have a much more thorough search, a little bit of a kind of systematization of both the topics which you had been given. It's not that they're two separate topics, they're interlinked. So you have to be able to establish the relationship between a relapse and a tibialis anterior transfer. So just saying this paper is from this year, that paper is from that year, we can all read up the abstracts on that one line which you underlined. This is not how you do a literature search, really. It's not for writing up a paper, you're making a presentation. So you have to be able to collect all the points, put them down in a flow. And what are the aspects which have been dealt with enough? What are the aspects which have not been dealt enough? What are the strengths of each paper? Which are the best landmark papers? So please follow some sort of a, pattern. I think you're experienced enough now to know how to do these things. I have no
Yes.
questions.
Dr. Neeraj, are we done? We have two more other presenters, or are we good to go with the session? Rishi, are you there? Okay, so I guess we all can log out, and I don't hear anything from anyone, nor do I see the remaining presenters. So thank you, everyone, and thank you, OrthoTV.
Yeah. So thank you very much.
Yeah.
Yeah. Thank you.
Yeah.
Thank you.
Thank you, ma'am.
Maharishi, please stop the stream.
Thank you, sir. Thank you, ma'am.